Mainstay's ReActiv8 is an implantable device designed to electrically stimulate nerves to activate key stabilizing muscles of the lumbar spine. Chronic low back pain consists of an ongoing cycle of muscle weakening, pain, and activation suppression of the core spine muscles by the brain. ReActiv8 is designed to stimulate the nerves responsible for contracting the multifidus muscles. The brain senses the muscle contractions, and in response can trigger restoration of muscle control. With the multifidus again providing joint stability, the continuing cycle is interrupted, facilitating a recovery from chronic low back pain. Now to present the ReActiv8 implant procedure. Prepare the patient. Prior to starting the implant procedure, fluoroscopic imaging is used to square the end plates of the L2 and L3 vertebral bodies in both the AP and lateral views. With the end plates squared, the skin is marked to show the optimal placement for the guide needles at the medial cranial edges of the L3 transverse processes. Also marked is the midline above the spinous processes. While this is a typical incision location, assessment of anatomy should be performed prior to the procedure to determine an ideal incision point. The location for the IPG pocket is optimally identified preoperatively to account for typical patient posture. Guide needle placement. With patient preparation complete and the end plates of L2 and L3 still squared, a guide needle is placed at the cranial edge of the L3 transverse process, just lateral to the margin of the superior articular process. The guide needle trajectory is parallel to the C-arm axis. Guide needle use can increase lead placement accuracy, decrease procedure time, and reduce radiation exposure. The resulting guide needle placement is perpendicular to the plane of the intertransversarius. The intertransversarius is the plane of muscle which resides between adjacent transverse processes and is the structure in which the lead is fixated. With the guide needle positioned, a 45-degree trajectory is traced from the guide needle tip to the skin to determine the optimal delivery needle insertion point and incision location. Determine the needle entry angle. The midline incision is made at the determined location, dissecting down to the supraspinous ligament. A small stab incision is then placed through the supraspinous ligament at the fascial insertion point determined previously. The stab incision is kept just lateral to the spinous process, as close to the bone as possible. This will allow the smooth advancement of the instrumentation through the ligament and fascia, and will provide consistent insertion of the leads as close to the midline as possible. The delivery needle is then inserted through the stab incision, angling laterally and anteriorly towards the tip of the guide needle. Trajectory and placement is confirmed using both AP and lateral imaging. Final placement of the delivery needle is accomplished when the delivery tip extends just beyond the plane of the intertransversarius. The downward trajectory of the needle should be approximately 45 degrees to the intertransversarius plane. Guidewire deployment. With the delivery needle in position, the guidewire is inserted. The guidewire should exit the delivery needle straight and extend 5 to 10 millimeters beyond the tip of the needle. Placement of the guidewire is confirmed using both AP and lateral imaging. Place the introducer sheath. When the guidewire placement is complete, the delivery needle can be removed. The guidewire should be supported during delivery needle removal to prevent it from retracting. It is recommended that the contralateral guidewire also be placed before moving on to the implantation of the lead. After guidewires are positioned, begin the implantation of the leads. The introducer assembly is placed over a guidewire and advanced to the level of the skin, again with the guidewire supported during manipulation to keep it in a stable location. The introducer assembly is then inserted into the tissue, following the same trajectory as the guidewire. Deviation from this trajectory can result in kinking of the guidewire. Placement of the introducer assembly is complete once the entire distal dilator tip of the introducer sheath is just beyond the plane of the intertransversarius. Placement should be confirmed on both AP and lateral views. At this point, the guidewire and dilator can be removed. The dilator is disengaged from the introducer sheath by rotating the hub counterclockwise relative to the sheath. The introducer is supported during dilator removal to prevent the sheath from retracting. Position the lead and deploy tines. Once the dilator and guidewire are removed, the ReActiv8 lead is placed via the introducer sheath. Insertion of the lead should be done using fluoroscopy to avoid overinsertion. The lead is inserted until the distal electrode is within the plane of the intertransversaris. This placement will result in the distal tines being on the anterior side of the intertransversaris. The introducer sheath can then be retracted 3 to 5 centimeters, exposing all 4 electrodes. Do not remove the introducer sheath completely at this point. The lead is gently tugged to deploy the proximal tines on the posterior side of the intertransversaris and complete the fixation mechanism deployment. The lead is gently pushed and pulled back and forth. If the lead placement has been completed successfully, there will be resistance in both directions and approximately 2 to 3 millimeters of play in the lead position. Lead placement is confirmed using both AP and lateral imaging. The contralateral lead is then implanted following the same steps. With both leads placed, twitch testing for multifidus muscle contraction is performed to verify lead positioning. Strain relief loop. With the introducer sheath still in place protecting the lead bodies, blunt dissection is completed at the level of the posterior thoracolumbar fascia to create a pocket ipsilateral to the IPG location for placement of the strain relief loops. Once all dissection is complete, the introducer sheaths and the lead stylets can be completely removed from the lead body. Tunnel leads and implant the IPG. The IPG pocket is created using blunt dissection and should be kept tight around the IPG to reduce the risk of migration. The pocket depth should be 4 centimeters or less from the skin surface to allow for communication between the IPG and the other ReActiv8 system components. The lead terminals are then tunneled subcutaneously between the lead implant incision and the ReActiv8 IPG pocket. Once tunneled, the lead terminals are cleaned and dried and then installed in the IPG header. The provided torque wrench is used to secure the leads within the IPG. Excess lead is coiled and placed around or behind the IPG within the subcutaneous pocket, but not on top of the IPG. Follow the natural path of the lead as it exits the IPG header to avoid sharp bends. The IPG header contains suture holes for securing the IPG to the fascia. A section of lead is left by the lead implant incision during IPG implantation to facilitate construction of the distal strain relief loops. Strain relief loop. Using the excess lead retained previously at the muscle insertion point, form a 2 to 3 centimeter strain relief loop and place into the previously created pocket. Implant finalization. A final set of system integrity and twitch testing for multifidus muscle contraction is then completed. Final system placement is confirmed using both AP and lateral imaging. The incisions are closed and the implant is complete.